بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Now we'll discuss the second part of the topic dealing with imaging of the ankle and foot by MRI, and we have finished with the ankle joint, and we'll start now the evaluation of the foot. We'll have some words about the avascular necrosis in the ankle and the foot, ankle impingement syndromes, fractures of the ankle and foot, and miscellaneous issues including Morton's neuroma, plantar fasciitis, TORF2, pigmented villonodular synovitis, diabetic foot, Charcot neuropathy, gout arthropathy, and finally some words about osteoarthritis. Starting by the avascular necrosis, which is a disease affects a lot of the bones in the ankle and foot, particularly the talus, and this is known as collar disease. Affection of the the affection of the navicular is known as collar disease. Affection of the calcaneus is severe disease, and the affection of the head of the second metatarsal bone is known as Freiberg disease. The causes of avascular necrosis are either idiopathic or secondary to trauma or secondary to the use of corticosteroids or secondary to bone marrow infiltrative lesions. The Taylor avascular necrosis is graded into 4 grades. Grade 1 is just a diffuse bone marrow edema of the Taylor bone. Grade 2 is cystic changes in the area of the dead bone. Grade 3 is separation of the dead bone without displacement. And grade 4 is displacement of the separated bone. Of course, the stage of bone marrow edema is seen by MRI more better than any imaging technique, where you can see that the talus is of low signal in the T1 and high signal in the T2 weighted image. If you have a bone scan, it will show positive findings, and this stage can be mistaken for a lot of diseases like the just bone marrow edema of transient osteoporosis or bone marrow edema secondary to trauma or contusion. Then this stage is not a pathognomonic of avascular necrosis unless it is followed by the second stage or the stage 2, where you can see that the dead bone is transformed into cystic area with low signal in the T1 and high signal in the T2 weighted image. And this is also an example of stage 2 avascular necrosis of the talus, and you see there is a low signal in the T1 and high signal in the stair with no separation of the bone. When the dead bone is separated, then you are dealing with stage 3, and this is an example by MRI, and this is also an example by CT, coronal reformatted image. When the separated bone has been displaced from each side, then you got a defect in the bone, which is appreciated by MRI and also by CT, and then you are diagnosing stage 4 avascular necrosis of the talus. Then Kyler disease is avascular necrosis of the navicular bone. This is a self-limiting disorder, and it affects the children or boys between the age of 3 to 10 years, and is commonly unilateral, but bilateral disease can be seen in about 25% of the cases. As in any of the avascular necrosis of anywhere in the body, and you got some sclerosis of the dead bone, flattening, fragmentation, and maybe secondary osteoarthritis of the related joints. Then you know that the blood supply of the navicular bone is rich from the periphery but is poor in the central part. So the navicular is prone to develop this type of a vascular necrosis, which, as I have mentioned, is self-limiting and it resolves by itself considering uh, the conservative measures. On MRI, and you got flattening of the bone, and before flattening, and you got bone marrow edema, as similar to the stage 1 vascular necrosis of the talus, which is of low signal in the T1 and high signal in the T2. Then in order to differentiate the avascular necrosis from, let's say, infection of the tarsal bones. In cases of infection, you got erosion of the cortex, you got soft tissue abscesses, and you got overlying cellulitis. But in avascular necrosis, and you got just bone marrow edema of the navicular with, of course, partial or complete collapse of the bone. Then the Freiberg disease, which is an osteonecrosis of the metatarsal head, commonly affects the second metatarsal bone and is bilateral in about 10% of the cases, seen more commonly in girls in between the age of 10 and 18 years. And the high heel is one of the direct causes of this particular disease. The complaint is pain on weight bearing with swelling and tenderness localized to the affected metatarsal bone, which is commonly the second one. Then by plain X-ray, and you got some flattening and cystic changes in the head of the second metatarsal bone. First, you got widening of the metatarsophalangeal joint, and later on you got fragmentation, bone sclerosis, and maybe osteoarthritic changes. It's worth to know that some metatarsal head flattening can be seen in about 10% of asymptomatic population. Before the stage of fissuring and fragmentation, bone marrow edema can be displayed by MRI, and here you can see in the second metatarsal head the localized area of bone marrow edema. Later on, there will be collapse, fragmentation, and bone sclerosis. This is the classification provided in the literature for the Freiberg disease, considering stage 1 as metatarsal head flattening with decreased subcortical bone density. Stage 2, metatarsal head sclerosis, fragmentation, and cortical thickening. Stage 3 is development of osteoarthritic changes of this metatarsophalangeal joint. Then before, as I have mentioned, the changes have appeared in the plain X-ray. You can see the changes by MRI in the form of bone marrow edema, which is not specific for this particular disease. Bone marrow edema can be secondary to trauma, can be secondary to occult or stress fractures, and can be secondary to infection. But in order to diagnose Freiberg disease, there should be some flattening and irregularity of the metatarsal head. And here you see a classic appearance of Freiberg disease with cortical depression, bone sclerosis of the second metatarsal bone. Then severe disease is a affection of the calcanean apophysis, and many of the lesions are not seen by the plain X-ray. They are better appreciated by MRI. This occurs in children and young adolescents, especially who are performing jumping and running sports. And severe disease is usually diagnosed clinically. The radiographs may show normal findings. Sometimes they may show the changes of avascular necrosis like bone sclerosis, fragmentation, and collapse. Then here you see a relative bone sclerosis of the calcanean apophysis with some fragmentation, and according to the literature, this corresponds to Osgood-Schlatter disease of the tibial tuberosity and the little league elbow of the medial epicondyle. By MRI, you can see bone marrow edema, which will appear as a low signal in the T1 and high signal in the STER images. Also, you may appreciate bone marrow edema in the adjacent part of the calcaneus. Then we came to the ankle impingement syndromes, and we have posterior impingement, anterior impingement, and this rare one, which is the calcaneofibular impingement. The posterior impingement is thought to be the cause of repetitive ankle plantar flexion and is classically described in ballet dancers. Then there are many causes for impingement and a posterior impingement of the ankle. One of these causes, and is a common one, is osteogonum, which is a separated bone behind the calcaneus, or elongation of the stida process. The lateral process of the talus is long than enough, or is appreciably long, and this will interfere with the mechanics of the posterior aspect of the ankle. Third cause is elongation of the posterior tibial process, as you can see here, or fractures of the lateral process of the talus, or inflammation posterior to the talocalcanean joint, or this bony spur in the superior aspect of the calcaneus. There are 6 causes. The first 2 are the most commonly seen in the clinical practice. Then associated with impingement, there may be retrocalcanean capsular thickening and synovitis. You got some inflammation around this elongated stida process of the talus, and you got some fluid around, and also you may see bone marrow edema of the process itself. Sometimes you got tenosynovitis of the flexor hallucis longus tendon, and you may got soft tissue edema posterior to the talus. And this is a good example of posterior ankle impingement where there is elongation of the lateral process of the talus with surrounding soft tissue edema. There is no fractures, there is no osteogonum, and there is no bone marrow edema of the talar process. And this is also elongation of the lateral process of the talus known as the stida process with the surrounding soft tissue edema of the related soft tissues. And also you may see in the axial image that the flexor hallucis longus tendon is surrounded by fluid, denoting the presence of tenosynovitis. The Achilles tendon is intact, as you can see here. Then anterior ankle impingement is also caused by repetitive trauma with impingement of the anterior tibia against the talus in those who have some dorsiflexion of the ankle. Then painful and limited dorsiflexion of the anterior joint line of the ankle with anterior ankle swelling, and you may got some bone marrow edema and synovial thickening of the related soft tissues along the anterior aspect of the joint. Then here you see this small process projecting anteriorly from the inferior aspect of the tibia, and another protrusion here together with thickening of the capsule of the joint and some soft tissue edema related to the lesion. Also, you can see that the anterior talofibular ligament is considerably thickened, maintaining its normal signal, denoting chronic strain or chronic injury. And here, anterior ankle impingement is usually diagnosed by the presence of a small bony process in the anteroinferior aspect of the tibia and also a bony process in the superior aspect of the talus, together with the soft tissue edema and the capsular thickening of the area in between. And this is a case of severe osteoarthritis of the ankle joint that has resulted in very prominent and osteophytic limbing. This will also lead to anterior ankle impingement, but this is, and the ankle impingement here is secondary to this osteoarthritic changes. Now we came to the calcaneofibular impingement, and normally you can see that the talus is interposed between the fibula and the calcaneus. And in normal conditions, there is no direct contact between the fibula and the calcaneus. But if there is osteoarthritic changes here in the talocalcaneal joint, there will be some valgus deformity of the calcaneus. Then the talus will go medial and the calcaneus will go lateral. Then there will be a direct contact between the fibula and the talus, resulting in this calcaneofibular impingement. And this is the demonstration, and you can see that there is marked narrowing of the talocalcanean joint with valgus deformity of the calcaneus and displacement of the talus medially. Now the fibula is facing the calcaneus, and this will result in severe stress injury here, where, as you can see, narrowing of the joint spaces, bone marrow edema, and osteoarthritic changes. Normally, if you draw a line from the axis of the tibia and a line along the medial border of the calcaneus, it will form an angle less than 6 degrees. But in cases of osteoarthritic changes of the talocalcanean joint with narrowing of the joint space, there will be valgus deformity and the angle will be so much increased, and this will allow direct contact between the talus, between the calcaneus and the fibula, resulting in this calcaneofibular impingement. And the osteoarthritic changes of the talocalcanean joint are evident here in the T1 and the stair with subarticular pseudocystic changes and degenerative bone marrow edema. In the coronal image, you can appreciate that the talus has displaced medially, and now the fibula is facing the calcaneus with severe degenerative changes, subarticular pseudocystic changes in the joint interfering between both. And this is another example of displaced fracture with a hindfoot valgus deformity and 2-year history of diffuse ankle pain. And if you look here, the same situation, there is valgus deformity of the calcaneus facing the fibula with tri-compartmental osteoarthritic changes between the fibula and the talus, as well as the calcaneus. And this is 2D sagittal and coronally reformatted CT images after ankle joint arthrography, showing the classic appearances of calcaneofibular impingement. You see severe osteoarthritic changes of the subtalar joint with almost total obliteration of the joint space, prominent osteophytic limbing of the articular surfaces. Then you can see that there is direct, almost direct contact between the calcaneus and the fibula, with this articulation developing secondary osteoarthritic changes. Now we came to the fractures around the ankle and the foot. The ankle fractures are classified by Weber into 3 types, A, B, and C. And the fracture the fracture type is detected according to its position in relation to the syndesmotic complex. You remember that we have two ligaments on the lateral aspect of the ankle, the talofibular ligaments and the syndesmotic complex. The syndesmotic complex can be appreciated in the plain X-ray at the point where the fibula is almost in contact with the tibia. This is the site of the syndesmosis. If the fracture is below the syndesmosis, this is type A. If it is at the level of the syndesmosis, this is type B. If it is above the syndesmosis, this is type C. And this film will show the three types of fractures and also the mechanism of injury in each type of these fractures. Okay, then these are once more the three types of fractures, and the type A is below the syndesmosis, and this is the site of the syndesmosis. And then if you can see from the video that frequently the medial malleolus is fractured as well during the three types of trauma. But you have to decide or to see the fracture type, and this is the site of the syndesmosis. The fracture is below, and this is type A. Look carefully for the medial malleolus if it is fractured or not, and also look behind the ankle for fracture of the posterior aspect of the tibia. If this is fractured and this one, the fracture is known as trimalleolar fracture. Type B will involve the fibula at the level of the syndesmosis, and the syndesmotic complex will be ruptured in more than 50% of the cases, and it may be also associated with rupture of the deltoid ligament and medial malleolar fracture. This is an example, and you see the fracture is at the level of the syndesmosis with the fracture of the medial malleolus as well, and this is type B. And here is a type B fracture. You can see the fracture at the level of syndesmosis, the nearest point between the fibula and the tibia, and the medial malleolus is intact, and this is an accessory ossicle at the medial malleolus. Type C is the fracture above the syndesmosis. The syndesmosis will be injured. The medial collateral ligament will be injured as well, with possible fractures of the medial malleolus. Then here is a fracture above the level of the syndesmosis. The medial malleolus is intact, and also the posterior malleolus is intact. This is what I mean by trimalleolar fracture. It is a fracture of the lateral malleolus, medial malleolus, and the posterior aspect of the tibia. This is known as trimalleolar fracture. And here is another example, and you see the fracture of the fibula, the fracture of the medial malleolus, and if you look carefully here, and you can see the fracture of the posterior aspect of the tibia. Then complications of fractures around the ankle include dislocation or subluxation of the ankle joint, stiffness, osteoarthritis, ankle instability, non-union, and malunion of the fractures. When we came to the fractures of the foot, and we would like to have some words about Les France injury, Chopard injury, avulsion fractures, snowboarder fracture, Jones fracture, calcanean, and stress fractures. The Les France ligament is the ligament between the second and the first metatarsal bones. And this ligament is ruptured during or by a crush injury on or axial load to the plantar flexed foot. Then, if the ligament is ruptured, then you got separation between the first and the second metatarsal bones, which is easily appreciated on the plain X-rays. Normally, if you draw a line along the medial border of the second metatarsal bone, it will form a gentle curve with the middle cuneiform bone. But in cases of Lisfranc ligament injury, you got widening of this space, and if you draw a line, there will be a step deformity like this one, diagnostic of Lisfranc injury. And this is Lisfranc injury, and you can see this wide separation between the second and first metatarsal bone. And if you draw a line, and you will got the step deformity between the metatarsal and the middle cuneiform or the intermediate cuneiform bone. This is diagnostic of Lisfranc injury. And then the short part, injury is a fracture dislocation of the mid-tarsal joints of the foot. It affects mainly the talo-navicular and the calcaneocuboid joints. Actually, this fracture is well appreciated in the lateral X-ray of the ankle or the sagittal images of the CT or MRI. The foot is usually dislocated medially and superiorly, as it is plantar flexed and inverted, frequently associated with fractures of the related bones, the calcaneus, the cuboid, and the navicular. But the talus usually remains intact and its relation with the tibia is preserved. Then, if you have the frontal X-ray and the oblique X-rays of the foot, this is the normal frontal and oblique X-rays, and this is the Chopard injury. You cannot appreciate the injury. All you can see that there is this disturbance of the relation of the tarsal bones with loss of the clear joint definition between the bones itself themselves. Then, if you have the lateral X-ray, this is the normal relation between the calcaneus and the cuboid, the talus and the navicular. But you can appreciate easily here that the foot is dislocated superiorly with disruption of the related joints. And if you have the CT scan, you can also see this is the normal appearance of the talus and the navicular and the tibia. The talus will remain or may maintain its relation to the tibia, but there is disruption of the talonavicular and calcaneocuboid joints with superior dislocation of the midfoot. Then the fractures of the fifth metatarsal bone include avulsion fracture, Jones stress, and shaft fractures. These are the four types of the fractures. Then in young persons, you have to discriminate between the line separating the apophysis from the fracture line. The apophysis before being united to the shaft, the line separating will be more vertical or oblique, but the fracture line will pass horizontal like this one. Then if you look to this foot and you see that there is a avulsion fracture of the tip of the fifth metatarsal bone, and 90% of the base of the fifth metatarsal fractures affect this type of the avulsion fracture, and it is usually seen in tennis players because of the frequent inversion injuries of the ankle and foot. And this fracture has an excellent prognosis. And if you draw a line separating this part of the metatarsal bone from the shaft, this is the actual site of the avulsion fracture. If the fracture is above here like this, and this will be Jones fracture. And this is an avulsion fracture of the base of the fifth metatarsal bone. And this is what I mean by Jones fracture. If you draw a line here, this line will indicate the site of the avulsion fracture. But if the fracture is above, then this is Jones fracture, which has a high risk of non-union. And this is the Jones fracture. It is well above the site of the avulsion fracture of the base of the fifth metatarsal bone. The lateral teral process fracture, also known as a snow border fracture, because it affects usually those who are playing on the snow. And this is the appearance of the fracture by coronal reformatted CT image of the ankle. This is the fibula, and this is the tibia, this is the talus, and you again got the fracture of the lateral process of the talus. This fracture may be missed on the plain X-ray, but it can be easily appreciated on the CT scan. This is the sus tentaculum tali, which looks medially. Then this is the lateral process of the talus, which is fractured. Then we came to the calcanean fractures, and the calcaneus is the most commonly fractured tarsal bone. It accounts for about 2% of the fractures and 60% of all tarsal bone fractures. Sometimes it is known as the lover fracture or Casanova fracture because in the old days some of the lovers used to climb the tree or the pipes reaching uh, uh, the girl who are loving, then many times he is discovered by the parents and they try to jump from a from a height and fall in his ankles with commonly fractured calcaneus, and the fracture is usually bilateral and may also be associated with spinal fractures. There are many angles to judge the calcanean fracture, but usually the fracture is evident in the plain X-ray and then the CT as well. If you draw a line tangential to the superior surface of the calcaneus and another line tangential to the posterior surface of the calcaneus, then you measure the angle between these two lines. This angle should be in the range between 20 to 40 degrees. If the calcaneus is fractured, it will be flattened and the angle will be decreased and it become less more than 20 degrees. Then if you draw two lines along the superior surface of the calcaneus and you measure the angle in between, this angle normally ranges between 95 and 105 degrees. If the calcaneus is fractured, the angle will be more wide and it may be greater than 130 degrees, or even there is no an angle at all, the surface will be flattened. Then this is the normal calcaneal angle, and this is the angle of fractured calcaneus. You can see the flattened calcaneus and the angle is decreased. And this is bilateral calcanean fracture for a male 25 years old, jumped from a height and landed on his feet. Then you got comminuted fracture of both calcaneus bones. And here you can see that the calcaneus is flattened and the angle is almost lost. Sometimes minor trauma may result in stress fractures, and MRI is one of the best modalities to see the fractures of the the stress fractures of the calcaneus by demonstrating bone marrow edema around the fracture line. And if you have the plain X-ray, you can miss the fracture site, but this also can be easily identified by the strong uptake on bone scan images. There are a lot of classifications for calcanean fracture affecting the lateral part or the medial part, the articular surface or not, but all what we can provide as radiologists is to mention the site and the type of the fracture, and very importantly to indicate if it has disrupted the articular surface or not. Then stress fractures are seen commonly in runners, and then the third metatarsal shaft is the commonest site for this type of the fracture. Many times you cannot see the fracture itself, or you may see a prominent callus formation at the fracture site, or just you can identify localized perosteal reaction, meaning that the fracture has been healed and the residual changes are only seen. It's also important to note that stress fractures are not always visible on the initial X-rays. If suspected, the X-rays may be repeated, or you may have MRI to better see the fracture site and the surrounding bone marrow edema. And we came to the Morton's neuroma, which is known as intermetatarsal neuroma, and this is not a neuroma by the mere word. This is just a very neural fibrosis around the plantar digital nerve. And these are the plantar digital nerves, and the site of the neuroma is commonly seen in the third metatarsal space, and less frequently it can be seen in the second space, but the rest of the spaces are rarely affected by this disease. And it is frequently the result of irritation of this space by, let's say, minor trauma or something like this. Then you got very neural fibrosis forming a mass, which is painful, and this lesion may be bilateral in about 10% of the cases. Then here is the MRI of a patient with Morton's neuroma. You got a dumbbell shaped lesion insinuated between the metatarsal heads in the third, commonly in the third space, and this lesion, being a fibrous tissue, will appear black or of low signal in the T1, relative minimal increase signal in the T2 weighted image, but if you inject contrast, it will show significant enhancement. Then we came to the plantar fasciitis, which means inflammation of the plantar fascia, and is considered the most common cause of heel pain. This pain is usually felt on weight bearing. The causes include the stress or repetitive trauma, like in runners, for example, degenerative, or in some of the arthropathies like seronegative spondyloarthropathy, ankylosing spondylitis, Reiter, and psoriasis. And in the plain X-ray, you can just see only a calcanean spur. But this is not diagnostic of plantar fasciitis, since the calcanean spur can be seen in asymptomatic personnel and is not an indication of plantar fasciitis. But in order to diagnose plantar fasciitis, you should have MRI looking at the plantar fascia, which is in those patients will be thickened and will show abnormal signal. It may be ruptured and also may show soft tissue edema in the heel bed of fat in the form of low signal in the T1 and high signal in the T2 and the stir images. And you can compare these appearances by the normal plantar fascia, the normal thickness, and the normal soft tissues around the fascia itself. Then here you can see by the plain film calcanean spare, and this is not enough for diagnosis of plantar fasciitis. By MRI, you can see the fascia is thin and you got some fluid signal at its anatomic site, and also you can see edema of the subcutaneous soft tissues. If you have a bone scan or isotope scan and you got evident uptake related to the site of inflammation. This is the normal plantar fascia, and this is the fascia which is affected by inflammation. We came to the TORF2, and this is a stress injury due to extreme dorsiflexion and hyperextension injury of the toe, as you can see here. And this is frequently referred to as sand toe, as it is common in sand volleyball players. And this pattern of injury will put too much stress on the ligaments and the tendons related to the big toe, will result in this particular disease, which is known as TORF2. This is seen in professional athletes, but not specific for a particular type of sport. Any sport which is associated with this position can lead to this injury. And you know that the big toe and at the metatarsophalangeal joint, there are two sesamoid bones that are connected by a ligament known as the intersesamoid ligament. And each sesamoid bone is connected to the phalanx by a ligament which is known as the lateral and the medial sesamoid ligaments. Any injury of this ligamentous complex or any strain and soft tissue damage will result in this TORF2. And here is a drawing after removal of the head of the metatarsal bone. You see the two sesamoids, medial and lateral, the intersesamoid ligament, the ligament connecting the sesamoid bone to the phalanx, and this integrity should be maintained in order to maintain the function of the big toe. Then here is the coronal image of the foot at the level of the first metatarsophalangeal joint, and you can see that there is capsular stretching and some soft tissue edema here and there, which is diagnostic of TORF2. Then you can compare the normal appearance of the ligaments and the rupture of the ligament with soft tissue edema at the site of the ligament. And you should have the coronal images in order to see which sesamoid ligament has ruptured, to differentiate between the medial and lateral one. Like this here, and you can see this is the normal appearance of the ligament, and this is rupture of the medial sesamoid phalangeal ligament. Then we have some of the issues that has been discussed previously in many topics, in the topic of polyarthropathy and in the knee, and maybe in different joints, and this is the pigmented velonodular synovitis. This is an idiopathic disease of unknown etiology. It is a monoarticular disease, results in painless swelling of the joint, and pain will develop after progression of the disease with affection of the bones and articular surfaces. It is the sequelae of deposition of pigments in hypertrophied synovium, resulting in big synovial masses interfering with the mechanical joint movement. And these pigments will produce masses of low signal in the T1 and the low signal in the T2 weighted images. But if you inject contrast material, they will enhance after contrast injection. These lesions are treated by removal of the synovium. And in this image, you can see big low signal masses in the T1 weighted image in the back of the ankle joint and some smaller lesions in the anterior aspect of the joint. And here you can see low signal lesions in the anterior aspect of the ankle in both T1 and T2 weighted image. If you inject the contrast material, and the lesion will enhance. And this is also pigmented volnodular synovitis, big mass posterior to the ankle, a smaller one anterior to the ankle, low signal in the T1, low signal in the gradient image. If you inject contrast material, the lesions will enhance. And this is also another example of pigmented villonodular synovitis of the ankle, a bigger mass anterior and a smaller one posterior. But you remember, in order to diagnose this as pigmented villonodular synovitis, the lesions will appear dark in the T1 and dark in the T2 weighted images, and they will enhance after contrast injection. Then we came to the issue of diabetic foot, and the changes in the foot of diabetics are secondary to the combination of reduced blood supply due to arteriosclerosis, reduced sensation due to peripheral neuritis, and the superadded infection. The changes will start by the formation of what is known as callus, and this callus is, like you can see, is an indurated skin which is related to the pressure points, especially under the heads of the first and the fifth metatarsal bones in ambulatory diabetics, those who are walking here and there. But in bedridden patients, this callus will develop under the heel or over the heel and the lateral malleolus. Then this callus is made of indurated soft tissue. It will show low signal in all pulse sequences by MRI, and it will enhance if you inject contrast material. Later on, the neuropathy will result in skin dryness and fissures, and this will result in ulceration, which is aggravated by minor trauma. And these ulcers, if they reach the size of 2 centimeters, they will penetrate the underlying soft tissues, resulting in sinus tracts. And these sinus tracts will provide an access for the infection to go deep in the soft tissues, and this may result in soft tissue abscesses and also may affect the bone, resulting in osteomyelitis. And the penetration of the skin and the subcutaneous tissues by this inflammatory process is known as cellulitis, and cellulitis is confined to the skin and subcutaneous tissue. Later on, the infection will affect the muscles and deep facial planes, will result in a mass of inflammatory granulation tissue known as the phlegmon. When this mass liquefies and suppurates, it will result in an abscess formation, and this abscess formation being intimately related to the tendons of the foot may lead to tenosynovitis, and this tenosynovitis may result finally in tear of the related tendon. Then diabetic motor neuropathy will result in acute muscle denervation, which will present by muscle swelling and edema on MRI, and later on you got severe muscle atrophic changes and fatty infiltration. The role of different imaging modalities in evaluation of diabetic foot. The X-rays can show soft tissue swelling due to inflammation, can show vascular and soft tissue calcification due to arteriosclerosis, can show radio-opaque foreign bodies, and that foreign bodies penetration is common in diabetics due to associated neuropathy. And foreign body, if it is opaque, it will appear on the plain film. If not, it will appear as signal void structure in all pulse sequences by MRI, surrounded by inflammatory granulation tissue, which will enhance if you inject contrast material. Also, the plain X-ray may show gas shadows due to gas-forming organism or necrotizing fasciitis, can show bone erosions and bone sclerosis. And this is an example of diabetic foot with necrotizing fasciitis, and you can appreciate the extensive gases in the soft tissues. Also, by plain film, and you can see destructive changes in the bone secondary to osteomyelitis, bone resorption, fragmentation, and bone sclerosis. By MRI, you can see the callus lesion, which appears black in all blood sequences. You can see the ulcers and the sinus tracts. You can see cellulitis, phlegmons, and abscesses. And you can see foreign bodies, as I have mentioned. And also you can see bone marrow edema of the foot bones, osteomyelitis, bone erosion, bone sclerosis, and muscle atrophy with fatty changes. And you can see here there is soft tissue swelling uh, around the big toe with low signal in the T1, high signal in the T2, and post-contrast enhancement denoting the phlegmon of which is a mass of inflammatory granulation tissue. Also, MRI can see destructive bony changes, can see deep soft tissue inflammatory masses, can see skin ulcerations, and can see bone sclerosis if you got areas of low signal in all bulk sequences. You can see bone marrow edema, which will appear of low signal in the T1 and high signal in the T2. And this is also diabetic osteomyelitis with septic arthritis. The lesion affects here the middle cuneiform bone, which is black in the T1, bright in the T2 weighted image. You may not appreciate these changes in the plain X-ray because of the sensitivity of MRI for bone marrow edema. This is the affected bone in the T2. If you inject bone marrow edema of whatever etiology will enhance with contrast by MRI. And this image showed that also the third metatarsal bone is involved as well. Then you came to what's known as ghost sign, and ghost sign is an indication of the presence of neuro-osteoarthropathy with super added osteomyelitis. The signs means that you cannot see the margins of the bony lesions in T1 weighted image, but you can see the margins clear after injection of contrast material. And in this patient with diabetic foot, and you see an ulcer here, and also you can see soft tissue edema and extensive bone marrow edema of the calcaneus. If you inject contrast material, the bone marrow edema will enhance, and you got the osteomyelitis clear, and this is known as the ghost sign. Then one of the major complications of the diabetic foot is the development of neuropathic arthropathy or the Charcot joint, which has also many other underlying causes like spinal diseases, brain injury, and so on. And Charcot neuroosteoarthropathy, there is degenerative progressive destructive changes of the bones and joints of the foot, and this is secondary to the absence of sensation due to the associated neurological disorder and the super added infection as well as the traumatic insults. Today, diabetes is the most common etiology of Charcot neuroosteoarthropathy. Then, if you look by the plain X-ray, the affected joint will appear as if it has been hit by this very strong hammer. Then you got destructive changes, disorganization and fragmentation with bone sclerosis, fractures and fragmentations, narrowing or widening of the joint space, marked bony sclerosis, large amount of bony and soft tissue debris, periosteal new bone formation. And these are summarized in what is known as the 5Ds: disorganization, destructive changes, debris, density increase, and deformity. And this is the Charcot neuroarthropathy of the ankle and foot. Diabetes is the most common cause of this appearance. And in the early stages, you can see this as a clinical inflammation of the foot itself, but later on, and you got a change in the axis of the foot. This is the normal appearance, and this is the let us say flattening of the foot arches with bony debris in the superior aspect of the joint. Also, you can use MRI and CT for the diagnosis of Charcot joint. I think they will not add too much information to the plain X-ray. You see bone sclerosis, bone debris, destructive changes in the joints, and the derangement of the articulation between the affected joints. And gout is also one of the one of the diseases that cause lesions in the foot. And the gout may be primary due to overproduction of uric acid or failure of its renal excretion, or may be secondary to many of the diseases. The hyperuricemia will result in deposition of uric acid crystals in juxta-articular position, and this is commonly seen at the metatarsophalangeal joint of the big toe, but it also can affect the rest of the foot joints and also the hands. The erosions are classically sharp, punched out erosions, and they start adjacent to the joint line, and later on they will affect the joint line and may cross to affect the opposite bone as well. Then you got severe destructive changes and a big soft tissue mass, which is known as tophi, or the inflammatory granulation tissue that has resulted from this deposition of uric acid crystals. And you see affection of the interphalangeal joint and the metatarsophalangeal joint of the foot. Finally, osteoarthritis can affect any of the joints in the hand and in the foot and ankle, and the usual manifestations are similar to any osteoarthritis anywhere in the body, meaning that there is narrowing of the joint space, subarticular bone sclerosis, osteophytic lipping of the articular surfaces, maybe subarticular pseudocystic changes, maybe intra-articular gas, and maybe loose bodies, especially in large joints. Thank you very much. Alhamdulillah.